My name is Alfonso Barrera. I'm a plastic surgeon in Houston, Texas. And here I'm going to share with you what I have learned over the past 30 years or so in hair transplantation for both aesthetic and reconstructive purposes. My background is basically, I'm originally from Monterrey, Mexico, went to medical school there, and then did 7 years of surgical residency. After that, 2 years of general surgery at Methodist Hospital in Dallas, Texas, and then a residency in otolaryngology and head and neck surgery at the Harvard program in Boston, Massachusetts, and subsequently a residency in plastic surgery in Houston, Texas at the Cronin, Brower, and Biggs program. In 1985, 1987, I started getting a little thin myself. I wanted to find what are the best options for hair transplantation, and I was able to find a paper written by Carlos Ubel in Brazil. I learned a lot from Carlos. I'm certified by the American Board of Plastic Surgery and the American Board of Otolaryngology and head and neck surgery, and currently I'm proud to say I'm president-elect of the Texas Society of Plastic Surgeons. I have been already at the Houston Society, of the Texas Society of Plastic Surgeons, and in September I'll be president. Anyway, in a few moments I will share with you my preferred techniques for hair transplantation. One case will be that of a female patient who has scarring alopecia due to 2 facelift procedures. She lost pretty much all of her sideburn and most of the temporal hairline. She also had a little bit of loss of the frontal hairline. We're going to show you how I like to reconstruct that. And then we're going to have also a case of a male pattern baldness and one of a reconstruction of a mustache and eyebrow from a traumatic accident. In general, I prefer the strip method. That's where you take a donor strip from the occipital area and sometimes from the temporal areas. And out of that, with magnification and background lighting, we can dissect those strips into individual hair follicles quite accurately and be able to preserve about 95 to 98% of the hair follicles, as you will see in a few moments. As far as the placement of the grafts, I prefer the stick and place technique, where for the frontal hairline, I prefer the 22.5 sharp point blade. For the posteriorly, I like to use a feather 11 blade. For the mustache and for the eyebrows, I prefer the 21 gauge needle, in which I create the recipient slits, the recipient sides first with the 21 gauge needle and then position the grafts, as you will see. For the mustache, same thing, I use a 21 gauge needle to make the recipient sides again in the direction in which we want the hair to grow, and then place the grafts. So make the multiple recipient sides first and then place the grafts. In contrast to in the scalp, I usually will make the recipient side and immediately put the graft in. We'll show that in a few moments. I'm now going to share with you a case of a correction of scarring alopecia post-retidectomy, a post-facelift scarring alopecia. This is a 67-year-old female who has had 2 previous facelift procedures and a coronal forehead lift. She has lost a lot of her hair from the temporal areas, the sideburn completely lost, and the temporal hairline is way displaced. Her forehead, her hairline is displaced posteriorly more on one side than the other. And she is interested, of course, in restoring the missing hair. We're going to be doing primarily on her right side, bringing down the hairline just a little bit. She's happy with how it is right in this area, and we're going to work on the temporal hairline and sideburn. As you all know, this alopecia can be prevented, but there's a few cases out there that need help. And the cause of that, as we all know, is by making the incision along the temporal area. Many times the patient's told they're going to hide the scar here, but when we do that, many times as we then do the lifting, we end up displacing the sideburn, and that's exactly what happened with her. The way I normally prevent this from happening on my facelift patients by making a pre-hairline incision, a little bit millimeters into the hairline, but it's a pre-hairline incision around the sideburn, and that way, as we lift the skin from the face, you do not display the sideburn at all. Now, in this case, she has had the unfortunate situation of 2 consecutive facelifts and has lost a lot of hair. I'm going to start by ink marking the proposed hairline and show her the mirror, make sure we're in agreement, to make sure that she likes the plan, and I think she will, and then we get started. This patient had 2 previous facelift procedures, and as you can see, she lost completely the sideburn and most of the temporal hairline. And today we're going to restore that. It'll give her much better appearance and eliminate completely the evidence that she had a facelift procedure. We are going to strengthen the frontal temporal recession here, and then you're going to come down like this, trying to mimic just what a natural hairline would be like. More or less about like that. So we're going to be grafting all of this and strengthen the hairline all throughout here. The distance from the eyebrow to the hairline is 2.5 centimeters. So we're going to do the same on the other side for symmetry. So basically this is what we're going to be doing. In a moment we'll show the patient a mirror, make sure that she agrees with the plan. I think she will. Now I'm going to mark the other side. So I'm marking now the frontal hairline here. She has a little more of a recession on the right side than on the left side, and her preference is that we only add a little on the right side and nothing on the left frontal hairline. Then I'm going to come down here to strengthen again the frontal temporal hairline. We're 2.5 centimeters at this point, 2.5 centimeters from the eyebrow. And so we come this way. Basically, this is what we're going to add the hair, and we're going to strengthen all of this all back into here as well. And I think that'll be a good hairline. Let's take a look from the front for symmetry. I think that's good right there. Now we're going to show the patient a mirror, make sure that she agrees with that. Okay, ¿qué te parece, Silvia? What do you think? We can modify things. Let me make a little adjustment here for symmetry. Take a look again. What do you think? A little better? Mm-hmm. Let me take a look from the front. I think that's good, but we can adjust if you want to.
This line goes here, but this will be lower, I think. Maybe I will not. From here, it looks like here, and it goes.
You want a little higher, this side?
Yeah, this is a little higher, which I
like that.
I like better, I think.
Okay, so a little tiny bit higher, okay. Okay. Okay, now we have finally agreed that this is what she likes. I think that's aesthetically pleasing. And
now it's here. Yes,
we're going to be adding hair right here. all throughout here, into here.
Ujú.
Todo aquí, y acá viene lo más rápido posible todo esto.
Sí.
Here, maybe just a few here without bringing it down, just to connect this a little bit, without bringing it down. You agree?
Okay.
Okay. Okay, you can take a, yeah, okay. I'm just going to making some real final detail adjustments to meet the patient's requirements and taste. Right about there. I like to make it a little bit slightly irregular right here, so it's very natural. You don't want straight lines or rows. A little bit of irregularity is always good. Slight.
Mm-hmm.
Okay. No, I think that's really good. Let me just move this slightly here. Okay, now that we have agreed on the plan and the exact design of the hairline, and in that order, now we go on to get started. We're going to look for the donor hair, and we look for the hair that has the highest degree of density. So she has very good hair back here. There's no problem of supply and demand here. Their supply is plentiful. Their demand is not huge, so it makes her a very great candidate. Have a marking pen, Lori? I'm going to outline an ellipse about 18 centimeters in length and 1 centimeter in width. Let's take this off here. I have the marking pen, marcador. Okay, so we're going to go about 1 centimeter in width. Okay. They have the measuring tape. Lo siento de medir. That's good density. I think that'll be good for see all the hair here. It has 18 centimeters in length and it's basically about 12 millimeters in width. Excellent. So you're going to make a ponytail to hold the hair up there. So once we close this, it'll be completely concealed the donor side also. We're estimating to make about 2,000 grafts with this. It's about 18 centimeters in length, but it's actually about 12 millimeters in width. This way, doing it in narrow and long, we can go without tension. And this way, it heals so well that you can hardly find any evidence, even looking for it, of the donor side scar, especially incising parallel to the hair shaft, as we will do.
Can you lean forward for me? Okay, stick on your back, and then I'm going to recline you back, okay?
At this point, we're getting her, we're titrating the sedation to get her the right level of sedation. We're using midazolam and fentanyl, Versed and fentanyl. She got about 5 milligrams of Versed so far and 50 micrograms of fentanyl. And we just see how she responds, and when she stops responding to our questions, then we know she's ready. ¿Cómo te sientes, secreto? Bien? Doesn't seem to respond very much, so I think she's just about ready. This is 0.5% marking with a epinephrine 1 to 200,000. I'm using a 30 gauge needle, and I'm going to inject the caudal margin of the donor ellipse. I'm injecting the caudal margin of the donor ellipse, since the innervation comes from caudal to cephalic. I might as well start numbing the area that we're going to be grafting, so I'm going to inject a little bit of local right here in Marcaine, 0.5% marking 1 to 200,000. Okay, now we're going to go to the other side and do the same. Now this is the left half. I'm going to be numbing the left half of the donor ellipse. Again, 30 gauge needle, injecting the caudal margin of the ellipse with 0.5% Marcaine, with epinephrine 1 to 200,000. And now the area to be grafted. Just injecting the anterior and inferior margin will numb it up from that point cephalically. Now I'm using a 25 gauge needle, and I'm going to inject a little bit faster here now. Now she's partially numb, I can inject a little bit faster. She's very comfortable, taking a little nap, a little twilight sedation. Once we have her completely anesthetized, locally anesthetized, she can be awake and alert, and she can watch TV or talk to us. Again, 0.5% Marcaine, 1 to 200,000. Again, injecting a little bit faster now because it's partially numb already. I'm using a 25 gauge needle now. Okay. Now everything's completely locally anesthetized for the duration of the case. Now we're going to harvest the right half of the donor ellipse First, I'm going to do some tumescent infusion, tumescent infiltration. This is 0.5% lidocaine with epinephrine 1 to 200,000 and 40 milligrams of Kenalog in 120 cc's of saline. So again, 120 cc's our tumescent solution consists of 120 cc's of saline solution, 20 cc's of 2% lidocaine, 1 amp of epinephrine 1 to 1,000, and 40 milligrams of Kenalog, 40 milligrams of triamcinolone. Tumescing the area will help a lot for the dissection of the grafts and for hemostasis as well. Okay. All right, now we're going to harvest this. The incision, I'm right-handed, so I have to incline the blade a little bit here, and the idea is to go parallel to the hair shafts. I'm using 3.5 loop magnification, so I can see very well what I'm doing. Incising parallel to the hair shafts. In the female patient, a lot of times this will peel very nicely, like almost like a banana skin. See? You go just deep enough to clear the hair follicle. You don't want to go too deep, so you preserve sensory nerves and vessels. This is the first half, the right half of our ellipse. And if you look up close, you can see the incision is made quite parallel to the hair shafts. On both sides we go, as parallel as possible to the hair shafts. Okay. Now I'm going to close. I'm going to use a simple running through of proline. Okay, shuffle from the hair a little bit. As you can see, there's not much bleeding, and I haven't even cauterized anything, so. No need to undermine. I like ellipses that are narrow enough that you don't need to undermine. Those heal the best. Besides, the scalp is not very elastic, so even when you undermine, there's not a whole lot of advancement of the flaps by undermining, unless you undermine all the way down to the neck. Whenever you have tight closure, you would have to undermine all the way down to the neck to be able to recruit some skin mobility, because the scalp is very, very inelastic, and it won't advance much even after undermining a few centimeters. You have to go a long distance caudally to get some recruitment of skin and close without tension. For the reason I like to avoid that problem, I just take a narrow, long ellipse that we can close easily. As you can see here, there's zero tension. It's not tight at all, the closure, and I didn't undermine. There's no room for a hematoma in these cases. There might be a little stain on the dressing, but there's no dead space. So that's a good thing. I can comfortably do this procedure and leave town the same day, not having to worry about hematomas or problems. The follow-up is very simple. We'll go over that later, but basically, we'll leave a bandage for 48 hours, which the patient will remove him or herself and start gently shampooing at that point. As you notice, I'm not using Adsons. Adsons are also traumatic to the scalp, to the hair follicles. When you're pinching, you can traumatize a little bit the scalp, so I try to not even use the Adsons. Or if I use them, it's just to pick up the needle, not to pinch on the tissue. Okay. In a few moments, we're going to turn the head to the right. As you see, the patient is supine, and the head hair is turned to the left. We have taken the right half. We're going to continue supine, turn the head to the right, and take the left half. Let's punch a little bit. Enough here too. Yeah, this looks better. Looks nicer. Okay. Okay, we've closed now the right side, the right half. Now we're going to turn her head toward the right and work on the left half. So now I'm going to inject some tumescent solution here again. This is what Carlos Ubel calls ballooning. Ballooning. And I like to balloon it, but not too much. Just about like this. Time blade. Okay. I'm right-handed, so here, if I went like this, I'm going to be cutting probably like perpendicular to the hair follicles. I need to go this way. So I'm parallel to the hair shaft again. Can you see that pretty good? And I'll make the other side. Here too, we're going parallel to the hair shafts. All right. Let's punch a little bit. So here we have the ellipse, and as you can see, it's nicely parallel to the hair shafts. Now let me show you how the incision has been made parallel to the hair shaft, as you can see right here. The hair shafts are all intact. which is what we want. So we can save them all, or good about 95% of them. Now we're going to close again with 3 of proline. Simple running suture, no need to undermine. I'll take the adsones just for the needle, to hold the needle only. Okay, hold her head towards the right. No need to use Vicryl underneath, I go straight to the proline. After 10 days, these sutures are removed, and it healed very nicely. When there's no tension, and when the incisions have been made parallel to the hair shafts, it heals really well. Often you have a hard time even finding this scar the next time when it's done this way. Now follow me. Again, notice it's coming together very nicely without tension and without the need to undermine. As I mentioned before, doing it this way, there's not any dead space, and so there's no, he cannot have a hematoma from this because there's no space for the hematoma. You may strain the bandage a little bit, but there's no risk for hematomas. I like that. When you undermine, then there is some risk for hematomas. I need to adjust the position of her head a bit. We try to part the hair as best as we can, so we do not incorporate hair in the closure, of course. Okay. Okay, we're done with that closure. Now we let the hair down. Not completely hides it the same day, the donor side. So here, my assistant, Lori, is securing the donor ellipse with a 25 gauge needle. So here's the tip of the ellipse, and so she can produce traction and then more easily dissect between hair follicles. She's going to make these slices about 1 to 2 millimeter in thickness with intact hair follicles on both sides. Almost every single time, about 95% of the time, all the hair follicles are intact. It is tricky and it requires a lot of skill. Fortunately, I do have a very good team, and they are able to do this very, very well. I used to do this myself, but it takes you a lot longer. You better have a team that can help you a lot and facilitate and do this more time efficiently and accurately. As she's doing that, and as our other assistants are cutting grafts, I normally continue doing the closure of the donor side, which we have already done this time, but or I give me a little time now to see some patients, some follow-ups while they're processing the grafts, dissecting the grafts. She's trying to demonstrate to you here the intactness of the incisions that she's making. You can see on both sides, on the slice that is next to it, is you can see the hair follicles intact, as well as where they came from, and she continued doing this until she processed the whole ellipse. And then subsequently, they're also divided into individual hair follicles, as you will see. That's a Mantis microscope, 10 power magnification that she's using. It's a visor, as opposed to, you don't have the binoculars, it's just a visor, makes it a little more comfortable for the operator. And we maintain the ellipses chilled, as you can see over there on that cup. We keep them chilled on saline solution. There's ice underneath that cup. Underneath the petri dish, there's ice to maintain it nice and cold. I think we'll have enough for about 2,000 grafts there. What do you think, Lori? Yeah, they need to be on the small side, yeah. In the meantime, you can focus there on Jesse, who's cutting grafts over there, too. This is a very, very important step of the procedure to dissect the donor ellipse into individual grafts which are intact and handling them atraumatically so they can have a very, very good chance of growing. Normally we have well over 90% of the hair follicles that we transplant and grow hair. And the main thing is, again, dissecting them intact, handling atraumatically, keep them wet on saline solution, cold saline solution, and then gently transplant them. We keep the patient throughout the procedure monitorized. As you can see, O2 saturation 100%, blood pressure is fine, the EKG. Like in any other procedure, we just monitor the patient very thoroughly. She's taking a very nice nap. She's resting comfortably while the grafts are being ready to be transplanted. Here she's going to prepare the half of the donor ellipse, and as you see, she's going to use a 25 gauge needle to secure the tip of the ellipse. Notice she's doing it in a way that the ellipse is kind of horizontal to the background lighting silicone gel board. And now she can use a little bit of traction with adsones and start dissecting with a 10 scalpel blade under 10 power magnification. These 1 to 2 millimeter thick slices with intact follicles. It's not easy to do this, and it requires a lot of practice. Lori's been practicing now for about 15 years doing this, so she can do it very well. So I'm going to change the blade. You want very sharp blades always. Periodically you change your blade. So here you can see she's making this nice dissection of intact hair follicles on both sides of the incision. And then subsequently divide that into individual hair follicles with 1 or 2 hairs for the front hairline and 1, 2, 3, or 4 hairs for the back. You can see here the slices that she has made so far. We keep them chilled, and a petri dish from saline, and then underneath the petri dish we have an ice container, so keep them nice and chilled, about 4 centigrade Celsius. Over here we have two other of our members of our team, Jesse and Pam, and they're dissecting those thin slices that were just dissected into individual hair follicles with graft with 1 or 2 hairs for the front hairline and 3 to 4 hairs for the back. In about 30 minutes, we should have about 300 to 400 grafts ready to go, and then we start putting them in. In the meantime, the patient is resting comfortably, taking a little nap, and all the girls are making the grafts. It's very important to have a good surgical team. I'm very fortunate to have a team of the 4 of us. These 3 girls, 2 are RNs, and Lori's a surgical assistant, and those are great. I'm injecting tumescence solution to the recipient site here in preparation for the grafting. Again, this will help for hemostasis and facilitate the placement of the grafts. So we have harvested the donor hair. The grafts are being dissected. We have about 400 grafts ready to go. And now we're going to apply a little bit of tumescence to the recipient site here. And then we're going to start placing the graft with a 22.5 sharp point blade. Okay, ready, Pam? It's a 22.5 sharp point blade. We want to incline the 22.5 sharp point blade in the direction in which we want the hair to grow. So we can see some fine hair here. We're just going to mimic that. For now, we're maintaining a pretty significant distance between grafts, because if we go too soon, too close, they tend to pop out, and it's very frustrating to have that happen. So just take our time. Later on, another half an hour or so, we can go in between these grafts, in 20 minutes, so we can go between these grafts and be closer between each other. Towards the end, we're going to be about a millimeter and a half to 2 millimeters between grafts, about 25 grafts per square centimeter. (25 to 30 grafts per square centimeter). This is just the beginning. We're going to be here for a while until this is really nicely densely packed. I used to use a 65 beaver blade and 511 blade, but sometimes they leave a little bit of scarring. With this blade, there's no visible scarring, no detectable scarring. This blade leaves no detectable scarring. As you can see right now, there's still a pretty significant distance between grafts because we're just starting the case, and we try not to go too close too soon because then they pop out. Like that, you saw how it popped out a little bit there. We try to prevent that by keeping a little distance between them. And once the fibrinogen turns to fibrin, then the graft hold better, and then we can go closer. Towards the end, will be about a millimeter to 2 millimeters between grafts, about 25 to 30 grafts per square centimeter. So we continue inclining the blade in the direction in which we want the hair to grow. In a consistent direction downwards and a little bit posterior in her case. Sometimes it's more in this direction when hair is kind of down and posteriorly. See now the fibrinogen being turned to fibrin, and we can go a little bit closer in between with very few popping outs. It's time to go to another area. We're going to go up here to give this a little time for the fibrinogen to turn to fibrin, so the grafts are more stable, and then we can place the grafts closer to each other. So we're going to go up here now. As you can see, there's very little bleeding. That's because of the tumescence infusion with a little bit of epinephrine. And you have to just patiently continue putting them in. You cannot be in a rush, it's just one by one. So far, I've always been here for every single graft. I make the incision, and again, my assistant, in this case Pam, she introduces the graft into the slit. So basically I select where it needs to go and the direction, and she puts it right in. She uses my blade as a shoehorn, if you will, to slide in with the graft. Another blade. The blade again, I'm going to change to a new blade. Okay. You have to change the blade as frequently as possible, as frequently as needed, so you always sharp blade. That way there's less pressure when you're trying to put grafts in and less chance for popping out. As you can see now, the grafts have been there for a few minutes, so the fibrinogen has turned to fibrin and it's a lot less likely for grafts to pop out. Little by little, we get them closer and closer to each other until we end up about 1 millimeter to 1.5 millimeters between them. In another couple of hours. This is just the right side. We're going to have to do the left side. Yeah, no rush. Take your time. So I select the inclination of the blade and the location, and then Pam, my assistant, slides the graft in. In the meantime, we have 2 other assistants still cutting grafts and lining the grafts in towels, surgical towels, so we then put them in. We started with 400 grafts there a few moments ago. There's now about there's 100 and there's 200, 10 by 10. There's 200, a little over 200 grafts there, and about 200 grafts here so far. So we just keep doing the same, continue placing the grafts until we go really close between them. So in my opinion, this is the best way to reconstruct this kind of scarring alopecia, because yeah, you could do flaps, but they don't look nearly as natural as what we're doing. This really will mimic nature. Sometimes, a year later, we do a second session to further increase the density. In about a year. If necessary, for more density, we go a year later and make it thicker. But you're going to have a great improvement in just this one time. Everything going very smoothly. Do you have any pain? No pain, right? It's totally a painless procedure. Isn't that great? They say no pain, no gain. That's not true. There's no pain and there's gain. Like here, where there's already some hair, we're going to just go in between the existing hair to minimize any trauma to the neighboring hairs. Yeah. Every now and then we use a solution of, it's about 1/3 peroxide, 2/3 saline to clean the area, and we do like this. So we can see better what we're doing. You don't want to just avoid any friction. If you do friction, you're going to pull some grafts out of place, so you don't want to do that. As you can hear, the patient is resting very comfortably, taking a nice nap. So here I'm inclining the blade, placing it there, lift a little bit, and open a little entrance for the graft to go in. See, like this, and then lift a little bit, and there's an entrance. Slip, and then lift, and there's an entrance. Create a little opening for the graft to slide in. Here we're going in between existing hairs, just increasing the density. So we just continue putting the grafts in little by little. We're going to be doing today about 2,000 grafts, and in a given case like this, generally about 90%, conservatively about 90% of the hair follicles will end up growing good healthy hair. And the hair will grow as permanently as it was going to grow in the area where it came from, which is the occipital area, which as we all know is the most durable permanent hair we have. This patient is 67 years old. and the hair back there looks very healthy. So I think it'll last her for the rest of her life for sure. The hair growing here. Again, as I mentioned earlier, this happens when the incision is made in the temple, vertically in the temple area when you're doing a facelift. But then once you leave the skin from the face, you're lifting the hairline, then trimming a piece of scalp, so you end up displacing the hairline up. That can be prevented by making an incision when doing a facelift in a pre-hairline location. A little into the hairline, but at the hairline. That way, with traction and counter traction, you can even make the hairline come down a little bit when you do it like that. That's how I do it every time, and every single time you can prevent this from happening. So there's 400 grafts there right now. Here's the second towel of 400 grafts. They're in group for 100. Then by 10, 1, 2, 3, 400 grafts. That's the second towel. And we're going to have about 4 towels for a little more than that. No, about 5 towels. I'll be about 2,000 or a little over 2,000 grafts with 400 grafts each towel. I think time to change my blade again. This is a great blade, 22.5 sharp point. There's another one that is a 15 degrees, a little smaller, and you can use that one. Sometimes, like you can even use that one like on facial hair restoration. But on the facial eyebrows mustache, I prefer the 21 gauge needle. Never had for before. Here the hair implants will be a little bit that way, so I'm going to do the same. See, totally painless. Isn't that great? And no general anesthesia at all, just sedation local, totally painless. See, now little by little they're getting closer and closer to each other, as you can see here. With minimal to no popping out. Try to keep the popping out as minimal as possible. It's a pain in the neck, and it takes, for instance, more time to put them back in. So we try to keep that to the minimum. When you try to go too quick too soon, you end up playing the whack-a-mole. Put one in and 3 pop out, put one in and 2 come out, and then try to put it, just like that game. I don't know if any of you have seen that one, or play with your little kid, the whack-a-mole. Looking good. We'll get lunch here in just a little bit. We just have to wait for the patient to wake up, so she can eat lunch too, huh? We're going to complete pretty much the right side, then we have lunch, and then we can do the left side. The patient eats lunch too. Isn't that nice? Maybe I feel better when they eat lunch than when they don't. That's the only procedure I do for the patient is when the patient does get lunch in the middle of surgery. I'm going to start with about 800 on this right side. This is the second towel. That'll be 800 grafts on this one side alone. And then I'm going to go to the other side and do 800 also. And then I'm going to divide and have the remaining grafts so we do it evenly both sides as far as density. It'll be probably over 2,000 grafts. But this way we're making sure that we're distributing evenly in both sides by doing, say, 800 first here and then another 800 on the other side, and then add some more on both sides. When you do it this way, stick and place technique, you never run risks of skipping recipient sides or adding 2 in the same recipient side, piggybacking. It's just 1 on each incision. As you can see, we make the incision and immediately place the graft. Create the recipient site and immediately put the graft in. So there's no risk of putting 2 in 1 or skipping recipient sites. The only times where I will make most of the recipient side at once is when there's excessive bleeding, and that way I can let things coagulate and then put the grafts in. But again, there's no risk of piggybacking and skipping slips when you do that way. Okay, we're taking a little lunch break. The staff gets a little hungry. They just ate, and I don't want the patient to eat by herself, so we take a little lunch break.
Yeah, I'm thankful for that.
We've done the right half of the hair transplantation, and after lunch we're going to do the second half. Typically we start about 8 in the morning and finish about 2 o'clock, more or less. But so we don't want to wait until 2:30 for 1 or 3. So we're about 1 o'clock, 12:30. So that way we feel better, and the staff feel better, the surgeon feel better, the patient feel better, and we go back and continue. Okay, ready to go ahead again. We just finished lunch. The patient is very happy because she was kind of hungry. Now she feels a lot better, and actually everybody feels better now. We're ready to go and do the left half. So I'm going to inject some tumescent solution here. Okay, see, for a little while, see, I'm right-handed, so it's a little, for both of us being right-handed, it's a little more awkward, so. Here again, we're keeping a little bit of distance, about 5 millimeter distance between grafts at this point, so that they don't pop out. And once the fibrinogen turns into fibrin, then they hold well on, and we can go closer. So here we are re-establishing the temporal hairline and sideburn. providing a little stability of the skin by kind of stretching it like this, stabilizing it a little more. Otherwise, it's like too loose, you see. So I'm kind of holding it like that. Does it?
Yes.
I guess submerged in. So here we patiently work at placing the grafts too, and take our time until we again get them all densely packed. So here they need to go more like that, and here we go more like this. Just trying to follow the direction of the native residual here. Trying to mimic what she has. So on the side when we're going, if you look at this hair, it's kind of going down and back. So we follow that pattern. Now the hair here is going more in this direction. So we're going more like this now. For the first few times or anyone start doing hair transplantation, I think it's important to look for cases where the number of grafts are not greater than, like, say, 500 grafts or so, just to get the feel for it, because it's a big commitment to try to do like 2,000 at once. The first time I would not advise it. I myself, when I started doing it, the first one I did was only 900 grafts, and it took me about 13 hours, and I was exhausted after that. 900 grafts took about 13 hours. Today we could do 2,000 grafts in like 5 to 6 hours easily. So I start with a small case to get the feel for it. Don't try to start with 2,000 the first time, and once you get some experience, you can do a little bigger cases. Because you don't want to have a strip of scalp and have it go to waste because you don't have the time to put it in. You know what I mean? And also you need to be able to cut the grafts accurately so they will grow hair. This patient has scarring but has healthy tissues. If the skin was very adherent to bone, then I would do in advance fat grafting, autologous fat grafting first, and a few months later do the hair grafting so that you have a better recipient site. Our hair recipient site is good, so we just try going to doing the procedure. Or like in burn victims or people that have skin grafts on the scalp, it's very thin. The skin very thin is directly attached to bone. Those you better do first fat grafting, and then a few months later you can do the hair transplantation. Otherwise, there's not enough tissue into which to plant the graft. So we're tightening up the skin here to stabilize it better. Little by little, we get them closer and closer to each other. So there's 400 there. We need to do another like 500 or 600. I estimate in advance how many I think we need, and we try to come pretty close to that number of grafts. If we have some extras, we'll put them in too. We don't want anything to go to waste. And we'll have a little over 2,000 just as planned. Very nicely locally anesthetized. We maintain the blue towel pretty soaked wet in cold saline solution, so the graft remain wet. You do not want the graft to desiccate. We put them in the towel just before inserting them. Before that, they are soaking in a chilled saline solution in a petri dish, which is on top of ice. If we keep them chilled in normal saline, we'll preserve them for up to 48 hours if you give them chilled saline. That was a study done by Bobby Limmer. He was a dermatologist who did a lot of hair transplantation in San Antonio, Texas, and he studied the longevity of grafts on the towel, or prior to the insertion. And if you keep them chilled in normal saline, about 80% of them survive at 48 hours. Of course, you want to put them as soon as you can. We're putting them all in within like 4 to 5 hours. But even if it's 6 or 8 hours, 10 hours, it's still fine. I want to keep them chilled and wet in normal saline. It feels a little awkward for both of us. Normally I can sit and use my right hand, but here I have to be standing and positioning myself at an angle, or I can do this easily, and it's the same for Pam. Otherwise, it's for us much more comfortable to do the right side. Very little bleeding, as you can see. You want to do this as bloodlessly as possible so you can see well how you're doing. When we're dissecting the grafts, it's much easier to dissect dark hair. When the hair is gray or very light in color, it's more difficult to be seen and to dissect. Luckily, her hair is dark for the most part. We're almost done. We're going to be 2,064 grafts. We're putting here the last few grafts. They're very nicely, densely packed, the grafts. Give it the best density possible in one time. We're putting the last few grafts now. So we've done approximately 1,000 grafts on each side. Actually, a little over 1,000 grafts on each half. So we have a total of 2,069 grafts. Here's the last 10 grafts. We're almost there. And you can't rush it just one by one. So here we are with the last 10 grafts. Almost done. You can't rush these procedures. Just take your time. Nobody can be in a rush on this one. Neither the patient or the staff or the surgeon, of course. 2 more grafts. And the last one is here. 2,069 grafts. She's going to do great. A year, well, about 3 to 4 months, the hair will begin to grow. In 6 months, it's going to look a lot better. It takes about a year for the final result. After a year, if the patient wants to increase density, we can do a second procedure. And she's going to do great. With this one time, she's going to have a very, very nice improvement. And then again, further thickening can be accomplished in the second session. Now we're going to apply dressing, which consists of adaptic, Curlix, and it's adaptic Curlix on an ace bandage. Okay. We just finished. Again, it's 2,069 grafts. You can see on this way, you can see the design of the new hairline that will restore what was there before. Same thing on the other side here. And again, for the first 2 or 3 months, you won't notice any improvement, but in 6 months, it'll be a lot better. And it takes about a year for the final result.
I'm patient.
Okay. Well, was there any pain?
No pain. No pain at all.
Excellent. No pain. We had lunch. 2,069 grafts.
I slept over for the first hours, which was magnificent for me.
Not only this way. So you can see the design of the new hairline, which is basically what she had years ago. We're restoring just the missing hair that used to be there. So the real you is coming back.
Okay.
In 3 months, it will begin to grow, and in 6 months, it's going to look really good.
Okay.
And it takes about a year for the final.
Perfect.
And if you want further thickness, in a year we can do a second session. But we'll play by ear. We'll play by ear.
Thank you, all the team. Thank you. You're not only very good, that's very kind.
Okay.
Thank you all. Now
I'm just going to clean her up for a little bit. I'm going to show her that. On the females, we just really make sure that it's thoroughly cleaned and brushed. So we put the bands on, so they can't shower for 2 days. We don't want to make knot. So you will leave this on, today is Thursday, you'll leave this on until Saturday morning.
Okay.
And then you can remove the bandage, dispose of it, and shower.
Okay.
And I have some shampoo and conditioner for you.
Yes.
You'll use that for 1 week, okay? And then you can go back to whatever you want to use.
And what about hair dry?
You can hair dry, just not on high heat, or low heat, because you could have some numbness.
Okay. And do you think I will have some, impact on my
I don't think so.
No.
The swelling?
Right.
Yeah, I can send you home some ice packs that you can do.
From now, from today?
Yes, if you want to on the forehead. Most patients do not have swelling, but if you do, you can go ahead and feel free
I
to
will
use
do that from today. So where? In both my eyes?
If you had swelling, it would be the forehead eyelid region. And then the main thing when you're showering is you want to avoid friction. So you don't, you know how you would normally massage and scratch, you don't want to do that.
It's only to remove.
Yes,
Yeah.
perfect. No pain, right?
No pain.
Is that awesome?
How long will this can I keep it? told me from the very beginning that I might have alopecia sense again.
Oh, really?
Yeah, but every year.
You cross your fingers.
Yeah.
Does that feel okay?
It's like, yeah, one more time.
Breathe, eat.
Would you make a copy here or not?
I can make one down here. I can make a incision down here.
Okay, well, in summary, we had this 67-year-old female with scarring alopecia, secondary to facelift procedures. We ended up doing a total of 2,069 grafts. We started about 8:30 in the morning, finished about 2:30, so about 6 hours. That included lunch. It's a kind of tedious procedure, but it's so worthwhile. Patients are so happy when they see the improvement in the restoration of the missing hair. As far as the aftercare, as you saw, we applied a dressing which consists of adaptic, saturated with polysporin ointment, as a non-adhesive dressing, and then Curlix and an ace bandage. We leave this for 48 hours approximately. I tell them any time on the second day, at any time of the day, they can remove the bandage and gently shampoo their hair. I want to do it gently. If the water pressure is hard, better make it a little milder, the water pressure, but they can have the direct water out of the shower head come to their head and do the shampoo gently. For drying the hair, I suggest to just kind of blood dry with a towel, no friction. That's it. They shower every day from that point forward, shampoo every day. And at the 10th day, postoperatively, the sutures are removed from the donor area. For the first 2 to 3 months, they will not see much improvement. And in fact, some of the very short hair, the short hair that is in the grafts, some about 2/3 will shed temporarily. That's normal. That's called telogen effluvium. And about 3 to 4 months, it begins to regrow. And from that point forward, it grows permanently as the hair was going to grow in the donor area. In 6 months, there will be a very nice improvement. It takes about a year for the final result.